Thank you, Petra, for this nice introduction. Yes, I can confirm that my heart beats for women, and I'm really grateful to Canon because in the past years they helped me a lot in improving the application of ultrasound, mainly for surgical procedure. So today they asked me to discuss this title, so modern ultrasound technologies in ovarian assessment. I want to start by showing you these guys because I was really very lucky. It was the year 2000. I met and I spent some time with the Professor Valenti, so I could join the IOTA group since the beginning, just after the publication of the consensus on terminology. So in my presentation, I want first to share with you dealing with a modern technology for the assessment of patients with ovarian cyst. I wanted to summarize the fruits of this very, very long experience of more than 20 years together. I decided to put them in a very schematic manner, messages. I prepared 6 messages to share with you. Ready? The first message, in front of an ovarian lesion, first we want to know, is it benign or malignant? And the suggestion today from IOTA Steering Committee is to use a 2-step strategy. So the application of benign, modified benign descriptors, and when they are not applicable, to use Adnex model. But before that, I always teach my students, I always show this slide, and I teach them that if they learn at least to give the ovarian cyst a morphological name, they are able to provide a risk of malignancy. That's great. They can go to their boss and they can say, she's 33. I found a unilocular solid cyst. The lesion has a risk of 35%. That's a lot. But as I said before, the suggested steps are modified benign descriptors. So all cases with unilocular cyst less than 10 centimeters can be recognized as benign. In case of lesions not fulfilling these criteria, we can apply Adnex model. Adnex model now is so well known, so I don't want to waste the time. Just let's repeat that it includes 3 clinical variables and 6 ultrasound variables. The 6 ultrasound variables are quite easy to learn, to share, very objective, I would say. The largest tumor diameter, the largest solid component, the number of locules, less or more than 10, number of papillary projection, 1, 2, 3 or more, shadow. Shadow could be a little bit subjective, but strong evidence of shadow is quite objective. And then ascites, so fluid outside the pelvis. How does it work? Let's look at this ovarian cyst. Do you remember my slide with the morphological name? We can call it unilocular solid. So we know that the risk of malignancy is 33. Done. But now we want to use IOTA model because benign simple descriptors are not applicable. So we can fill in the requested variables, so age, the type of center, the diameter, the solid component, no more than 10 locules, 1 papillary projection, no shadow, no ascites, we can use the model with or without CA125. Here it was available and it was a negative. We can calculate and we can get the risk of malignancy for this patient, which is 24%. The suggested cutoff is 10%. So the model is telling us that this lesion appears to be malignant. You can find, I put some QR code, the most important one, if you want to get it. Here you can find the accuracy of Adnex model, which is higher than 0.42, is about 0.44, both in the hands of experts and in the hands of non-experienced examiners, if properly trained during IOTA courses. So now all around the world, we are able to discriminate quite well with a simple method whether the cyst is benign and malignant. Let's move on to the second message. As a surgeon, a gynecological surgeon, gynecological oncology surgeon, in front of a patient of 33 years old with a unilocular solid cyst, it could be fundamental to know, is it a borderline? Is it invasively malignant? Is it a metastasis from breast, from colon, from stomach? So it's crucial to know, to answer these questions. And I couldn't imagine in the past that engineers could develop a model able to provide also the risk for this categorization for different subtypes of malignancy. But it happened. By using the same model, we can get not only the risk of malignancy, you remember it was 24%, we can look also at the relative risks for each category. And here, for this patient, you look for the highest relative risk. And so the model is telling you that cyst seems to be malignant, but in particular, it could be a borderline ovarian tumors. And of course, the clinical applications are very important because you can perform a fertility sparing surgery. So, borderline. As I said before, Adnex model is available. Now we are living quite a strange situation because we have to ask for the CE mark. Likely, unfortunately, some ultrasound machine like Canon, they did it. So they included in their machine, they got the CE mark, so it's available. During your scan, you can enter the variables and you can get those results. Key message number 3. Talking with our colleagues in North America, in particular from Canada and the States, it was not so easy to share our experience, but eventually we arrived to this important result. The name, the classification in all-rats category, as we do for breast cancer. It means that we can give a color for one particular, for that lesion, we can include that lesion in one of that category. And according to the color, we can plan a different management. But pay attention there. There is a result of Adnex, and in the middle, there is a column with the title Lexicon Descriptors, because our colleagues in North America, they prefer to maintain this description. So we merged, and in front of a lesion, you can calculate Adnex. According to the result of risk of malignancy provided by Adnex, you can decide which color, or if you prefer, you can scroll this lexicon to find your situation. let's try with this example. You remember that unilocular, solid, 33, adnex 24. Scrolling here, you can find the definition there. But even the result of 24 is corresponding to the intermediate risk. And the suggested management is conservative surgery, surgery even in the hands of general gynecologists. And for this category, patients should be referred to a dedicated gynecological oncology institution. And this is the corresponding value, adnex and the colors. You can find everything in this paper, named ORATS, so a sort of risk stratification and management system. But the great value of this paper is the collaboration of two words, so North America and Europe. I want to share with you in my lecture, I hope to have time, two clinical cases. So let's start with the first one. 69 years old, nothing relevant, asymptomatic. When she came to our attention, she already tested a tumor marker, and as you can see, C125 was negative, strangely. HE4 elevated and CA 90.9 elevated. She came to our attention after a magnetic resonance with the diagnosis of a unilocular solid lesion. PET was positive, and this is the lesion. So we confirmed the presence of this unilocular solid tumor. These are the variables that we need to apply IOTA models. So age, type of center, morphological name, unilocular solid, the largest tumor diameter, the largest solid component, we can measure that here. And then we call these papillary projections because the height of this protrusion is more than 3 millimeters. So we found at least 3 papillary projection, no acoustic shadow. Then color score was 3, so moderate. C125 was negative. Step 1, can we apply easy descriptors? No. We can try with the simple rules. I didn't describe in details simple rules, but perhaps you know them. There are 10 simple rules, 5 benign and 5 malignant. Oh, sorry, it goes, I wanted to stop. In front of that lesion, you can scroll one by one, and you see that only this one, more than 4 papillary projection, is applicable. So simple rules means that that lesion is malignant. And this is another tool that you can find in the American Journal. In the American Journal, a stratification again by using simple rules. So no more malignant than benign features. But let's go on testing IOTA adnex model. So age, diameter, largest solid component, more than 3, no shadow. C125 was negative. Here is the result. So first step, look at the risk of malignancy. Very, very high. No doubts. Second step, let's look at the relative risk. Here, the highest relative risks are these two, borderline or stage 1, better stage 1. This one. So, of course, we are dealing with high risk ovarian cancer. Diagnostic hypothesis. So, by using pattern recognition, we know that we are dealing with the 4 main categories of ovarian cancer. We hypothesized, because of the age, because of these categories, or killer cell or endometrioid. The patient underwent explorative laparoscopy and at frozen section, high-grade carcinoma was diagnosed. So she underwent laparotomy, total hysterectomy until residual tumor 0. I want to share with you the macroscopic appearance of the lesion. So with the solid component, that cystic area, just to show you one papillary projection, a clot inside. So we routinely try to share with our pathologist the slides just to understand, to learn more and more on pathology. And the final result was ovarian clear cell carcinoma. So Adnex was correct. Unilocular solid could be also borderline, but because of the large amount of solid component, the suspicion was right, invasive carcinoma. Second clinical case, 45 years old, breast cancer, the maternal aunt, but nothing relevant for this patient. She complained abdominal swelling. Ascites was present. CA125 was very much elevated. So we could say that in this patient, we do not need ultrasound with such elevated CA125, but she underwent a CT scan. And so CT scan documented an extensive diffusion of the disease with the peritoneal carcinomatosis. So before surgery, my colleague went to the surgery room and she was invited to look at the ovaries. I want to share with you because the two lesions are not so huge. You can see very thickened, very corpusculated ascites, and we can call this one multilocular solid lesion of 5 centimeters, so not very large. And this is this one. Now, so bilateral lesion, one of 5 centimeters, the contralateral 38 millimeters, with the same ultrasound characteristics. So moderate vascularization in the presence of bilateral lesion. For the application of IOTA models, you have to use as a target the largest one. The largest one, these are the variables that I summarized here. So again, we cannot apply IOTA benign descriptors. IOTA simple rules, again, we can scroll one by one. You remember multilocular solid? The only one is, would you like to be concentrated? No, none of the benign. Solid, no. Ascites, yes. At least 4 papillary projections, not really. It was multilocular solid, but no papillary projection. Multilocular solid larger than 10 centimeters, no. Color score 4, no. So only one malignant feature. And again, looking at this colored schematic table, again, red. But let's interrogate Adnex. Adnex, age, all the variables, according to the largest multilocular solid lesion, and on your screen, you can see the result. So very, very high, no doubt, even if it's not so large, but it's because of the presence of ascites, that's why. And looking for the highest relative risk, so first step, second step, no doubts, stage 2, 4. So very high risk. What about this patient? This patient completely different. Bilateral, ascites, carcinomatosis, no doubt. The suspicion was high-grade serous carcinoma. Could it be metastasis? Yes, could be, but in my view, it was primary. So I want to share with you the laparoscopic view because it's interesting. You can see carcinomatosis, but mainly I want your attention to be focused there. The tube, not enlarged, but a nodule there, connected to the ovary. And even the contralateral, not particularly enlarged outside, but look at the ascites, look at the carcinomatosis. So because of the extension, I didn't highlighted the fact that at CT scan, chest CT, there was also a supradiaphragmatic nodule. So at frozen section, this was the result. The patient during laparoscopy underwent right annexectomy, and because of the extension of the disease, the decision was to wait histology and to start neoadjuvant chemotherapy. I want to share with you the macroscopic view. So here you can see the right adnex with the ovary and the beginning of the tube. The final result was high-grade serous tubal carcinoma. And we know that this is the story of our patients, and unfortunately, screening is not available by using CA125 and ultrasound scan for these conditions, because we can be in presence of normal ovaries today, and in 6 months, we can find carcinomatosis because of this situation. And very often, BRCA is mutated in these patients. So we have been working on that here just to give you the neoplasia and the hilum of the ovary together between the tube and the ovary. Now, key message number 4. Key message number 4, we know that by using ultrasound, we can not only assess the ovary, the pelvis, but we can look at the abdomen. And we have been working on that for many years. And we found another important group in Europe working on that, Daniela Fischerova in Prague. So it was fundamental to go on, to share our experience. And here you can see the result of a big study published by Daniela Fischerova under the name of ISUOG study. So they compared preoperative exams like whole body DVI magnetic resonance, CT scan, and laparoscopy. We did a similar study, a prospective study with 264 patients, and we compared the assessment on ultrasound and laparoscopic findings. These are the parameters that we assessed, and I want to share with you just 3 videos. This is the omental assessment and the corresponding view. So a peristatic thickened tissue, okay, the omentum. Then, for instance, we try to look at the parietal peritoneal involvement, and you see here laterally, oh, I need my mouse, here. Okay, and sometimes this is not absolutely easy. You can see the peritoneum and their carcinomatosis. And sometimes nodules are so small, so diffuse, difficult without ascites. Of course, during surgery, you can remove almost everything except when you are in front of the mesenterial infiltration or several metastases in several lobes of the liver. But this is one criteria of unresectability. And you see the bowel loops retracted, fixed to the central part. And this is the corresponding video. Okay, here. When you enter with the laparoscope, it's not so easy to understand if there is a fixation or not, but then when you try to move them, you experience that they are fixed and retract. During live scanning in vivo exam, you can see that because they are not moving freely, but they are fixed. Now, talking about modern technology to assess ovarian carcinoma, I wanted to mention also this possibility to use fusion imaging. And again, thanks to Canon, I had the possibility to test this modality. So we did it for cervical cancer. And for those who are not experienced, it works in this manner. After for instance, this is a magnetic resonance, you upload the exam into your ultrasound machine. Then you have to synchronize. The patient is next to you. So you upload the exam. The patient is there. You start your exam. You synchronize the organs, the depth, the main anatomical point. And then while scanning, you scroll in your magnetic resonance. It's fascinating. The clinical value, we have to demonstrate that, but for sure it's fantastic because you can share, you can learn, you can improve your knowledge with your radiologist. They can learn and you can learn. And to put together, it's fantastic. So we did it also for the ovarian masses. We ran this prospective study and we assessed these criteria and we compared with the laparoscopy. Just a few videos. For great omentum. So we looked at the omentum and we compared the CT scan and ultrasound. Liver here and here. Then another example, looking at the lesser omentum. So we have to look at this. I need my laser. So here. And even during surgery, it's not easy to assess this area. So here you can see an example of this fusion method. Then parietal peritoneum carcinomatosis, very difficult to check some small lesions. And here together we could compare the two examinations. Again, diaphragmatic carcinomatosis, one clear example, but just to share that with you. And this one, bowel infiltration. Again, the two exams. This is a large ascites, so it's clear that these small nodules are visible. Sometimes it's not. So, to summarize the results, we found the fusion examination feasible, and we did independently, of course, in 2 different times, ultrasound and CT scan, and then we repeated the ultrasound together with the radiologist, and the results were very good. We have just concluded a multi-center study with Prague, and we are going to publish the results, so ISUOG as multi-center. Key message number 5. I don't know if I have some minutes or time is over. 5 minutes?
5 minutes.
5 minutes. So I cannot not to mention the intraoperative ultrasound examination. This is my great passion because, you know, this is my boss and he's so famous all around the world. He's not able to scan at all, but he trusted me a lot. So when I could enter into the theater and to guide him in some occasions, like in this patient, 33 years old, I found in the remaining ovary a small recurrent lesion of borderline. But during surgery, because the ovary was stuck, it was impossible to define the normal ovarian parenchyma and the small recurrent lesion. In that occasion, it was fundamental to use the laparoscopic probe. Laparoscopic probe, we could guide the surgeon and we could say, there is the lesion, this one, and next to the lesion, there is a corpus luteum. They didn't trust me at all, so they removed both, but at least the remaining ovarian parenchyma was there, and you see, they could remove the remaining lesion. Another example, clinically very important, because this patient, again, was 37, and she underwent surgery because of borderline. CT scan before surgery documented a precaval lymph node. So my colleague Ilaria was invited to go to the theater because they couldn't palpate. It was in fact enlarged but soft, not hard consistency. But when she looked at that with the small probe, she said that's metastatic. So we needed to remove that. So they did it, and at the examination of that small nodule, the diagnosis was low grade. So the management of that patient completely changed. Key message number 6, omic. Omic, perhaps some of you listened to my lecture yesterday. So omic means the use of radiomic. So the possibility from images to extract data. So the softwares are able to transform into data, into numbers, some characteristics not visible to our eyes. And as soon as you have extracted features, you selected those that are strong, stable, independent, you can create models. So just to explain, the main features are morphological, statistical, or textural. This is fantastic because here they provide you the shape, the volume, the area. These, they indicate the intensity in the pixel. But these features, they allow you to understand the homogeneity, the architecture, the texture. And I included these images. You can find them in my ultrasound unit. If I look at them and Dusan looks at them, we can say they are flower, simply flower. Radiomic, what does radiomic? Radiomic will transform these images in data and is able to recognize some figures that my eyes cannot explain. For instance, this one or even this one. So the harmonic, etc. So we have been working on that. In particular, in this paper, we analyzed patients with a BRCA mutation and patients with a no BRCA mutation, and we developed models to predict starting from the assessment of normal ovaries. Ongoing studies, we have been working on radiomic on solid ovarian tumors. We have collected our DICOM images available, and we extracted features, and we performed models to discriminate between benign and malignant, but even between primary invasive and metastatic. And we invited our colleagues in other countries to join us for this probe to study. So as IOTA AI, we have been working again on artificial intelligence, and this is my conclusion. We are in a new era. This is my last slide. As I said yesterday, we are working for the integration of our ultrasound images, our radiomic features, with other omics, proteomics, genomics, and the idea is to use artificial intelligence to build a new paradigm for a personalized and predictive medicine for our patients with ovarian masses. I thank you very much for your listening.